Okay, so in first place, I would like to thank Anik Nandi for organizing this series of lectures. I know in so many places, many of you are having a tough time with COVID right now. So I hope you, your family, and your loved ones are all right, or at least as good as possible. Un gran abrazo here from Argentina. You know, because of this academic system, so based on productivity, sometimes we spend more time reading than talking, and even writing than reading. So having this kind of events, even remote, is great to talk and exchange ideas and experiences. So I'm really happy to be here. So in this talk, I'm inviting you to an exploration of three things: a sociological approach to the concept of state, a proposal of how we can use this perspective of state in society for the analysis of language policies in indigenous healthcare programs in Argentina, and an ideological interpretation of these policies, which is both an exercise of discourse analysis, but also an exercise in hope. It is almost impossible to think about language policy and planning without a definition of state and its importance. As LPP studies were related to socio-political processes of democratization and nation-state building, there is an important line of research that assumes that nation-state is the most important agent in designing, implementing, and evaluating linguistic policies. Today, the glottopolitic perspective assumes such a strong opinion on the role of state. In the other pole of this somehow cartoonish scale that I'm proposing here, ethnographic approaches to grassroots language policy and planning are almost proud of actively ignoring the role of legislation, state administration, etc. Instead, a radical ethnographic perspective assumes that the state only exists as far as it is mentioned or intervened at the ethnographic sites, whether it is a community, a family, a church, a school, etc. What do these extremes, again, exaggerated, have in common? Both think of state as a homogeneous strategic entity, which can be described through a set of ideologically consistent discourses. In one case, those discourses are of the utmost importance. In the other, they are just an abstract declaration of principles with no practical effect on the actual languages, speakers, and institutions. To deconstruct this view, I think we need to denaturalize what we understand as a state in language policy and planning studies. I won't take into account philosophical but sociological definitions, oriented towards research questions such as what is the state, how does it work, what is its effective scope, and what are its contradictions. For more than half the 20th century, the structural functionalist conception of Talcott Parsons prevailed, who considered the state as the regulator of collective organization around a single set of values and norms internalized by society members. We see here why we don't like this liberal definition. In Latin America, the definition of Max Weber prevailed, for whom state was a human community that, within a certain territory, claims for itself the monopoly of legitimate physical violence. Perhaps even more widespread, especially in French or Francophile academic contexts, is the notion of the state as the political structure of a social formation made by Poulantzas. Shortly after, Poulantzas moved away from the idea of structure to consider the state as the material condensation of a relation of force between classes and class fractions. Studies on linguistic policies in Latin America consider the state as an apparatus that guarantees the domination of one social sector over the others, which projects a homogeneous and stable identity on the heterogeneous and changeable population through, among other resources, the fixation of a national language capable of catalyzing national identity, and with it, the common identity of the members of an imagined community. State appears as a subject, homogeneous and equal to itself, capable of tracing strategies and making decisions. Although diachronic changes and contradictions can be admitted, it continues to be presented as a character endowed with conscience and will. This approach to state is paradoxical. On the one hand, it is considered central and essential. On the other hand, however, there is only a very mediated approach to its actual social functioning through official text. This approach is external because it is only concerned with what is easily observable from the public space and in the form of a homogeneous series of documents, writings, legislation, etc. A question is missing here about how these discourses are produced and how they are interpreted. Indeed, the methodological operationalization of this definition is useful for theoretical coherence, but it makes decision-making processes, actors, and power relations invisible. If we adopt instead an internal approach to state, more than a collective actor that organizes and regulates, the state appears as a field of actors with different agendas, interests, and values, even contradictory to each other. From the perspective of the state in society of Joel Migdal, the state is a field of power characterized by the use and threat of violence that has two fundamental components. One, the image of a coherent controlling organization in a given territory, and two, the actual practices of its multiple parts. The image of the state tends to be that of a dominant, integrated, and autonomous entity that controls in a given territory all rulemaking, either directly through its own agencies or indirectly by sanctioning other authorized organizations, businesses, families, clubs, and the like. The practices, on the other hand, are the usual activities of institutional actors and state agencies. Its operation is not evaluated by a normative ideal, but according to its own codes and value systems, relatively autonomous from the image of the state and variable between dependencies. Thus, parts or fragments of the state can ally with each other, with external groups, to achieve and extend their objectives. This perspective requires new theories and methodologies, especially methodologies, that avoid the methodological nationalism that naturalizes the imaginary of the modern nation state, and the assumption of the existence of homogeneous communities spread throughout the national territory, defined by the equation, the very well-known equation, between population, territory, nation, and language. If we do not take a critical look at the ideological assumptions of the nation-state concept, we run the risk of pretending to analyze it using the same tools it provides us with. And those tools are made to exercise power, not to understand it. In Argentina, the public health sector serves 50% of the population, the most impoverished half. Although the National Ministry of Health sets the central objectives of the system and guides and conducts policies, provincial and local administrations have almost total autonomy in planning and executing their own policies. Although it finances national programs, such as the indigenous health area, it has little direct weight in its everyday management, which often depends on the relationships between provincial and local authorities. Actions in the field of public health, then, are undertaken by national, provincial, local, and community actors, from general hospitals to primary healthcare contexts, the salitas. In this talk, we will analyze some of the actions and discourses produced in these instances to understand their representations about language and communication and their link with health practices. We will focus on different actors defined by their distance with the actual practices of indigenous healthcare. The indigenous health area at the National Ministry of Health as an image projected by legislation and documents, the indigenous health officials, which actually write and implement, or so they say, those documents and legislation, indigenous health workers who work at El Sausalito, Chaco, with the important work done by Virginia Unamuno and her team of sociolinguistic action research, an indigenous health compendium used on-site by white doctors at the province of Salta with disparate, often null results, and 5 local officials and community leaders who participate in these activities and somehow semiotize the compendium. Since our approach to the linguistic policies of the state is not strictly sociological, we will analyze its internal diversity through discourses from various sources, documents, direct observations, and interviews. Discourse analysis will allow us to read the ideas about languages and their speakers of the actors involved, that is, their linguistic ideologies. We do not consider them to be a homogeneous set of well-defined ideas that tend to reproduce the status quo from position of power. On the contrary, we consider that they are a necessary dimension of the position of any subject as a speaker of language, a position that is implicitly assumed in most cases. In this sense, the analysis of linguistic ideologies is useful to understand the indigenous languages policies in healthcare, or the lack of them, since they are practical ideas with observable effects on daily activities. Hence, the constant reference to ethnographic and organizational aspects of our research. The effective impact of indigenous health area on health workers is very limited. The most important tool it has is the teaching of a community health training program called Interculturality and Health, Interculturalidad y Salud. In it, we see a restricted conception of interculturality limited to the contact between the white population and the indigenous population. The analysis of this material shows a representation of language as a single stable code shared and homogeneously distributed, as you can see here on the slide. Communication between cultures, or intercultural communication, is basically understood as the exchange of information through language, and it seeks to generate a space of mutual learning and enrichment. Here, culture is defined as information, so that interculturally is reduced to the exchange of data. Language appears as a neutral and homogeneous code shared by all Argentine population. In this conception of intercultural communication, there is no place for languages and linguistic diversity. This is due to a conception of the population as fundamentally monolingual, or at least mostly competent in Spanish. As you can see here, some of these peoples retain their native language in the family and community environment, although the majority understand and speak Spanish. The text proposes the presence of multilingualism as a private and community phenomenon that is outside the state's area of intervention. Spanish is the public language of all. Finally, the text does not see in linguistic diversity a value, but rather an obstacle for indigenous people to access health. The main purpose, as we can see here in the last example, the main purpose of the indigenous health area is to design and propose actions aimed at defining and removing accessibility barriers that condition the access to indigenous population to the public health system, be they economic, geographical, social, cultural, linguistic, or other. Indigenous languages appear here as a barrier between the population and the health system. In this sense, the role of indigenous health agents would not be to bring the state closer to patients, but to remove those barriers to bring patients closer to the state. Linguistic diversity and indigenous languages in particular are considered then an obstacle. Despite the fact that some of the indigenous health area members were authors of the documents analyzed, field observations in the health ministry and interviews allowed us to see some difference between them. In the first place, the indigenous health officials share the monoglossic view on language that we observed in previous sections. Bilingual health workers are treated primarily as translators in the preparation of materials and campaigns in the indigenous language. Unlike interculturality and health, indigenous health officials have a multilingual conception of citizenship. However, in the conversation, the provinces with the highest proportion of indigenous bi and monolingual speakers, Chanco and Formosa, are presented as different. You don't communicate with the community for linguistic and cultural reasons. Above all, they have other customs, more closed. We try to help as far as possible, whatever they let us. In general, they all speak Spanish, but if they do not understand well, it is necessary to translate to them. Finally, it is frequent also the use of the term language barrier to describe the relationship as officials with the communities. Communication with the communities is difficult because of the language barrier. We make sure that the health worker is bilingual as much as possible to overcome the language barrier. Indigenous languages are presented as an obstacle between the Western health system and the communities, and the role of bilingual health agents is reduced to that of a translator. The monoglossic representation of the language, together with the representation of multilingualism as a barrier, results in the conception of the health worker as a mere translator, as an intermediary who transposes medical knowledge from one code to another without having specific knowledge himself. This is the idea that we will see polemicized in the interview with one indigenous health worker at El Sausalito Chaco. Taking into account the presence of other voices of the state, this time in the primary care centers, the salitas, we note the emergence of different ideas about languages and their relationships with indigenous health. This is the case of B, a witchy health agent who was interviewed by members of the team of Virginia Unamuno. And here in the hospital, in addition to the health agents, are there interpreters, translators, shall we say? There are a few. I remember last year, when I was in the maternity ward, there was a girl who acted as an interpreter, right? That was before, but not now. Generally, when a doctor does not understand everything, he calls one of us. But it is not useful if the agent is not trained, because the health agent has to be auxiliary or nurse to be able to coordinate with the doctor what he says. The doctor, the nurse, and the patient. If a health worker is not trained, he will still ask him and he will not understand. He has to be trained. In this example, the interviewer uses the category translator without questioning its use in the context of the indigenous health service. B avoids the term, perhaps as a courtesy strategy to preserve the interviewer's image. But when asked, he reformulates his first answer, there are a few, to indicate that there are no longer any more translators. In his explanation for the absence of translator, he does not say that speakers of indigenous languages are lacking, but rather that these speakers lack medical knowledge. This valorization of the clinical knowledge of the indigenous health worker, and not only of their linguistic or traditional knowledge, is meaningful, as it is linked to a heteroglottic conception of language. It is not enough with being a witch speaker, you also need to know the medical code. Indigenous languages, for their part, are not presented as a barrier, as in the previous cases, but rather the difficulty of access is precisely the monolingualism in Spanish of public health. And here we see the quote. I believe that indigenous people have an opportunity to become health agents, that we can have the possibility of integrating and learning together with the white, the criollos, and face the things that are coming. As you will see, in every institution that starts, there are always, how do they say, semantic barriers, I think they are called. And the most critical barrier is in our language. Oh yes, and how would that be? Because they are not interested in our language. They do not want to know. And sometimes, many times, we want to teach to them, but they are not interested. In this passage, the change in perspective is evident between the white point of view, which is the indigenous language as an obstacle, and the witchy point of view, which is monolingualism in Spanish as a barrier. In this interview, it is monolingualism rather than diversity, the actual barrier. The lack of knowledge appears here on the part of the white doctors who lack simple linguistic skills, and not on the part of indigenous patients or workers. For me, the solution is to integrate and learn together with the white, the criollos. Once again, language and knowledge are inseparable, but so are collaboration and interaction between those who speak different languages and share different knowledge. The preceding analysis may run the risk of opposing stereotypically white and indigenous, officials and workers, as if they were two irreducibly opposed perspectives. However, we understand that these ideas about communication and language are not an ethnic heritage, a more or less essential property of two structurally defined positions. That is why we can find similar ideas in other portions of the state. This is the case of dialogues in Aboriginal languages, dialogues on health in Aboriginal languages. A small compendium developed by a retired doctor from the province of Salta who decided to prepare this material for working doctors in contact with Chorote, Wichi, and Guarani speakers. Despite their names, the dialogues are not conversations, but statements, orders, or questions that say nothing about the answers or possible answers by indigenous speakers. You see here in these three examples, the relationship between the participants is clearly asymmetric, since the use of the imperative predominates to give orders to the patient and not to listen to him or her. By not including a lexicon, it is impossible to interpret the response of a monolingual patient. This is incredible. They make open questions in 3 indigenous languages. How are you feeling today? But they do not give a clue about possible answers. Therefore, more than dialogues, the compendium proposes a monologue by the doctor in indigenous languages. Languages are considered as codes that guarantee unidirectional access. The source of language and culture and knowledge is Spanish. The content to be translated appears as identical, regardless of the target language and people. And the translation serves so that indigenous people can access that monolingual and stable Western knowledge. The compendium is preceded by a series of texts by local officials and community leaders of the province of Salta. In them, we observe similar ideas about language as we saw in other state actors. Here, the first example. One of the most difficult barriers to eliminate, see the metaphor here, linguistic diversity appears as a barrier to be eliminated in order to improve accessibility to the health system is the cultural barrier. This instrument will allow them to master constitutive elements in oral and written communication in these 3 languages, Wichí, Chorote, and Guarani, and thus be able to overcome existing language barriers, facilitating access to the health system for members of these communities. In this case, we observe the monoglottic conception of language as code, since it considers that the constitutive elements in communications are those that allow establishing the equivalence between universal concepts in particular languages. Although by its nature, an official multilingual material, these texts do not share the idea of the Spanish-speaking Argentina, the monolingual Argentina, the representation of the indigenous language as a barrier is all over it. The book, Dialogues on Health in Aboriginal Languages, is a brilliant contribution to help indigenous communities that do not speak Spanish find it difficult or impossible to communicate and explain their suffering. In this case, again, the barrier is placed on the native communities that do not speak Spanish and not on a health system that does not speak the language of its beneficiary. These ideas, however, of the language as a code and of the indigenous language as a barrier do not appear in all the prologues of the compendium. The text about the Franciscan priest, Jesus Galeote Tormo, starts from the opposite point of view, since it begins by indicating the need to speak the language of the other. There we observe, in the first place, that language is not conceived as a code that transmits information in a more or less direct way, but appears as indistinguishable from the knowledge of its speakers. The team of collaborators of Dr. Morales represents the voice that transmits the knowledge of the original communities, knowledge that is not reduced only to its own language, but to a whole set of beliefs and knowledge that each indigenous community possesses and whose learning has great value for the national community. By abandoning the concept of language as a code, the place of indigenous health workers can no longer be simply that of a translator between Western medical knowledge and passive indigenous patients, but rather proposes a symmetrical relationship between the two, close to the one we observe in the case of B. And again here, my wish is that conducive spaces can be created for the training and education of health agents, referring to language, culture, health, and all the indigenous problems, establishing an exchange of knowledge. Unlike the previous examples, linguistic diversity is not presented here as a barrier that indigenous people have to access Western medical knowledge. On the contrary, it is a gateway for Westerners to the culture of other people. The idea of intercultural dialogue is the opposite of that observed in the previous prologues, since it implies a passage of Western knowledge towards the community, but also the reverse direction. Linguistic diversity is not only not a barrier, but also functions as an opportunity to meet the culture of the other. So, in this talk, up to this point, we have started from a review of the concept of state to adopt a more empirical and internal approach, that of the state in society. From this perspective, we do not consider it as a homogeneous and identical agent capable of planning, applying, and evaluating policies, but as a field that projects an image but is fragmented into multiple practices carried out by diverse actors with their own agendas and ideologies. We analyze 3 dimensions of the object: the representation of population, language, and linguistic diversity. With regard to the first, we see an opposition between a monolingual or multilingual conception of the population, founded on the modern equation between state, language, nation, and territory. From the first point of view, Argentine citizenship and Spanish language are synonyms. Even when the presence of other languages is admitted, especially in the private or traditional sphere, Spanish is the only legitimate public language. From the second perspective, on the contrary, multilingualism is not associated with nationality, but with the speaker's skill. In it, there is no idiomatic assumption underlying the actor's national identity. On the contrary, diversity appears as a desirable feature of national identity. The second opposition is between a monoglossic or a heteroglossic representation of language. In the first case, languages are considered as a homogeneous and stable code, completely distributed among speakers according to the classic identification as a grammar and a dictionary. In the second one, on the contrary, languages are seen as a repertoire of styles, genre and registers, and varieties in constant contact. This idea is key to defining the role of bilingual health workers. From a monoglossic perspective, their main role is to be translators, establishing equivalencies between 2 codes. From a heteroglossic perspective, even between speakers of the same language, this equivalence is not automatic and requires specific knowledge and competencies and interpretive work. Finally, we analyze the representation of linguistic diversity as language barriers in access to healthcare. Indeed, the contact between a monolingual public system in Spanish and a mono or bilingual population in indigenous languages can be interpreted in different ways. For some, it is the indigenous who have a barrier, a handicap to access the system. For others, on the other hand, linguistic diversity is an opportunity to meet with the other's culture and knowledge about health. The analysis made it possible to reveal different configurations of these 3 types of ideological meaning, thus pointing out that the different areas of the state, according to different motivations, that may even be contradictory to each other. Although much work remains to test these conclusions, it is worth noting the role of experience as an agent of ideological change. In effect, the closer the actors are to the daily experience of indigenous health, the greater the sensitivity to multilingualism as a form of contact, not of languages or knowledge, or not only of languages or knowledge, but of speakers who speak, embody, and build that knowledge. We have thus defined the ideology of access as a modern ideology that seeks universalistic inclusion of all citizens, helping them overcome their handicaps, such as linguistic diversity, as a form of defending the equality of people born in different contexts. This ideology, however, is based on a monoglossic conception of language as a neutral code, and thus leads to a strategy that aims to facilitate access to that code. Hence, bilinguals are interpreters capable of translating information from one code to the other, and linguistic diversity is a barrier. The politics of identity, on the other hand, involve practical ideas about language which do not separate language and culture. Thus, language is heteroglossic by nature, not a code, but a set of varieties, voices, and styles which interact in every communicative event, and linguistic diversity is not a barrier, but an opportunity to widen our worldview and knowledge. Finally, one last word about resistance and hope, which is currently one of my main concerns. By challenging monolithic views of state, we can see emergent ideas and alternative linguistic policies which grow from within the same Western white capitalistic apparatus of the state. It is not just a matter of wanting a better world, but of refining our methodological frameworks to see better who, where, and how are actually making it happen. Thank you very much.